So I like to just supplement whatever the previous speaker said. This is another type of real-world data. It's a different type. And the purpose is I want to indicate what is the motivation using AI in this space. And what are the other type of real data we should interested look at into it. And what will be the next generation of healthcare will be like, instead of just looking at the back end side, the front end side, the whole process. So in a way that I want to using one example is a stroke. But before that, I hope this figure kind of motivate us. I think most of us probably know why we care about healthcare these days. Costly. In overall, we don't get our money worth. It is about 18.3% of GDP, huge amount, and all kind of things. And the government, a lot of agency, microeconomically, government, a lot of policy to try to make it work, sometimes make it worse. A lot of work to get done. Socioeconomically, we are consumer. We are starting getting a lot of asking for our right, how you use my data. And also equity asset, especially a pandemic, really show a lot of factors. All these factors really causing today why we care about healthcare transformation in this country. And very interesting. If you people look at the cost, we spend a lot of money. Actually, by the way, as a developed country able to spend healthcare is a luxury good. Probably miss the concept. It's a rich country's interesting things. It's affordable. If you can afford good healthcare, it's always good. That means your country is good enough, care about citizens, invest money on it. The problem is we spend a lot of money. We spend about 30% is wasteful. These 30% you can do much better. And people actually look at it. Some people do a study, break down the waste. And these are different type of wasteful. Administrative, pricing, value, drug prices recently with a law, and failure of care, over-treatment for all these kind of things. Each one, really, if you look at it, the thesis is really one of the thesis we ask, can AI really help at least reduce some of this problem so that we can actually save some costs, use the money to the real stuff. AI in medicine actually is not new. And in fact, FDA have approved a lot of products since last year, about 52 is escalating very fast if you look at this curve. And most of them in radiology, cardiology. Not surprising, right? Most deep learning are very, very pattern-oriented. So imaging and signals. So a lot of product actually embedded inside. You're using it, you don't know. Of course, we have a lot of business back office, IT, networking using AI stuff. This is general business. Particularly for clinical care, we do have AI product approved by FDA in the hospital being used. And most of these products, they are focused on specific tasks, require human to look at it. And I only touched the bottom. Actually, nowadays, if you go to hospital side, the smart hospitals start a lot of things. Biosensors, medical robot, omics data, socioeconomic data, something that the previous speaker had mentioned, outside the hospital incorporate into it, and kind of a concept of a hospital without war going forward. The concept of hospital is changing. It's not episodic. When people come to hospital, we're not just managing their coming in, it's a whole process of disease management. It's not a single point. Now, the question is, the more AI coming into it, the more automation into the different points, pinpoint in the process. We ask the questions, can we build some sort of digital doctor to help reduce the burden of the clinicians? And also staffing issue in the last pandemic already showed that a lot. And this is one of the theses is can AI help reducing costs, improving the power of the caregivers? That is the thesis. I want to take an example. Instead of talking concept, always good to come case example. One of them we want to show you about stroke. Everybody know about stroke is a major problem. About 800,000 people per year. And 80% in the Western world, stroke are acute stroke. I think in Asia, it's about 50% hemorrhage, 50% acute. The issue of the stroke is when you come to ER room using CT, most of them using non-contrast CT, very noisy, very hard to see. And we are not enough stroke specialists waiting ER room for you to come, especially in the rural area, small clinic communication. Diffusion MRI, which is a gold standard, unfortunately that is only available after hospital, after the patient administered into the hospital. It's really for monitoring confirmations, not really for triage or diagnostic. And this is a statistic, very sobering statistic. In natural average, we tendency, since we're not sure, we tendency overcall, do more. Overcall 30%, just in case, do more procedure, and see what happens. Unfortunately, even with that do more, we're still missing 20% of stroke cases. And meaning almost like flipping a coin, 50-50. This is the false positive rate, national average. This is the mild and moderate stroke cases data. And if you look at the whole process, we are not interested just looking at single point. Remember, when patient come in the hospital, you not automate one single point. You only care about patient coming in the hospital, we make sure the patient is healthy when they get out. So you look at the whole workflow. So if you look at the case of the ER room workflow for the stroke, and this is pretty much about the same across the country. You first come to the triage stage. You come here, see whether you have stroke or not. You look at you, talking, walking, touching, thinking. And then if it's becoming stroke cases, suspicious strokes, you go to CT scanning, non-contrast CT. And then if necessary, you could do more CT, HTP, more sophisticated CT. You're sure about that, and then your stroke team will evaluation and do treatment. Stroke is a diagnostic problem. It's not like neurodegeneration, Alzheimer's. Stroke, we have a lot of solutions of stroke, solving stroke problem once we know you have a stroke. The problem is we don't know whether you have a stroke, and let the problem propagate and causing a lot of money. So the idea is, the whole idea of a stroke is time is spring. You get it at the right time as soon as possible. So if you look at the whole process, we look at that whether AI can assist the whole workflow, not just single point. So we look at the triage stage. So can we automate that part? Reduce the redundancy? Yeah, you can actually. Because in reality, the triage nurse or ER doc basically look at patients. You look at the face and look at the movement, and then they have a standard protocol, ask you read something, and then judge whether you have stroke or not stroke, or stroke mimics, epilepsy or something else. These are the things that perfectly for AI to do today. And this is the type of real-world data. You don't have EMR, but you will be in EMR soon, any later. So you have an image, you have video, 3D video, you have voice, different type of voice, adversarial language model. And we did develop this package, actually, on iPad. And then you can look at the face, and there's this story called a cookie jar issue, in fact, in Boston. A whole bunch of Boston group developed in the 60s, people using it. And you read the story, in this particular case, the mother, a normal person would say the mother was washing the sink, washing the dishes, or obviously she's thinking about something because water flow through down the sink she is not aware of. The kid tried to steal cookie at the bag with the story almost falling, and she's not aware of. At least you can say something. And then based on how you say your pace, your wording, your abstraction, a good triage nurse can pick it up whether you have a stroke or not stroke. Together with your facial expression. The mild and moderate stroke, you have micro-segmentation, very tiny, hard to see. Human miss the small scene. Not the dramatic is easy to see, but this one is very difficult. But you look at the video in both, and we develop algorithms. Basically, we sync the video, audio stream, while they're talking, together with their video stream, 3D. And this is already done. These are algorithms. We train it in the original data. These are the data not available in EMR, not available elsewhere. Those are real-world data in the hospital. You have to capture it. And more people are capturing it. We also, at the same time, we're doing some high-level semantic that try to figure out the wordings they use. But surprisingly, just the voice and pitch together with the video, we get very good result. And this is some of the early stage results. That's by gender, age, ethnicity, and race, about 221 patients. Our performance is better than all other algorithms being published And the sad thing is even for CI, the green one, by the way, is the ER doc, emergency doctor. In comparison, it's the worst compared to all algorithms. And this is a sobering fact. We humans are good for general things, but humans are not very good when you're looking for specific problems. And machine actually can do better if you have no right framework. If I expand that into a little bit more detail, this is our model accuracy. CI means the clinical impression, or the ER doc diagnosis, everything. Imaging, EMR, all kind of thing. And this, in a nutshell, is in this particular clinical trials, our data is 72% versus 70% of the ER doc, which is not surprising if people work in deep learning. If you know what you're doing, if you have a good sample, the machine actually better than human. In this case, show a little bit of red, because when I was starting, I look at it, I go back to look at the data. We don't have that many African American in the training data set. I compensate afterwards. They show that the bias of data set is for real in the AI training. So we do the triage, second stage after triage, and then you do CT. So about evaluation of CT scan imaging. So I mentioned before, the non-contrast CT, the problem is they are missed in admission of the first 3 hours of stroke cases. The problem is, in CT adenema, right? You don't increase a lot of dosage. It's really a radiation stuff. Huge dosage. It's a radiation limitation. It's a limiting factor. Hard to insist the full dose at the same time. So you have both factors. So the way we are doing is we take advantage the stroke registry we have. Now, beside textual data, all the image data also in the raw form like in PACS. You can pull it out for the patient, for the last particular patient for 10 or 15 CT scan. We actually aggregate together and reduce the noise and use it to train a model, denoising model. This is very different from the other denoising. This is using normal CT to do the denoising aggregation compared to traditional using no-field CT, because that's the NIH data that people using it. This is using the hospital real-world data to train the model. And basically, what we do is leverage available data, temporal data of a patient, average out, this is a mean CT. So suddenly you have a dosage, just amazingly, you can have even 10, this is 6. You can even, you have 10 times more full dose. Reality, you only have one normal dose CT. You're like sitting. And this is some of the data I show you. This example, we are using a particular algorithm called ResCNN, but we modify a little bit. This original CT, you can look at it, the very noisy things. After you using denoising, you keep the signal. You reduce the noise. So integrity is still there, the architecture. You'll be able to see it. And we can achieve 2.5 to 3 times contrast enhancement improvement. And this deep learning model is platform independent, regardless Siemens, Philips, or GE machines. That's very important. So it's very generic. Okay, this will give you a little bit more clue why it's important. Original non-constant CT, you get an ER room. If I draw a circle here, that's what machine can see. But we know there are 2 types of tissue here. After our denoising, you can see clearly, you can tell the two types of tissue. This is the quality thing. We can do more quantitation. We also pull cases a year ago. For the same radiology, look at it. They forgot about which case they do. Star means that originally they missed all of them. I pointed to Ikeda here, you probably see it. But after we denoising it, show the same radiologist, and you can see they pick it up in the right the first time, 0 hours. That's very important. There are many other quantitative measures we can do, just want to give some idea. The quality has improved significantly, and this is very unique in the sense that using full dose CT 10 times to train. And we also compare with all other methods. Our method is quantitative, is better than all the existing one. It's very important. But actually, one interesting lesson we learned in this exercise, we tend to using, say, you need a big data to train deep learning. Not necessary. If you know your biology, you know your domain, that's what we learned domain for. I mean, instead of blind large data. In this particular case, only 300 patients, we get amazing result because we know what we're looking for. We're guided by knowledge of the clinical knowledge and also MR physics knowledge, CT physics knowledge. And the other thing is a lot of people tend to use data augmentation. My advice is, depend what you want to look at. Data augmentation adds a lot of noise into it. In this case, I want to denoising it. I'm not using data augmentation at all. And after you get such a wonderful image, right? These are the noise, and in fact, you can get a first time, get a whole brain network uptake, the whole brain edema, quantitatively. In fact, you can do many other things by using, once you have such a beautiful image, quality CT almost as good as MRI. You can do many other things. In fact, it might even reduce the need to do CTP and CTA. But the whole idea is try to get the original first time image, get the most information, as much as information as you can in the first time, because time is spring. You can't afford to patient do one scan, another scan, another scan, because we are competing with time, and also cost. So this is the diagnostic part. I told you the last one, and this one will be cooler actually. We just recently get it. We are interested in the whole total automation, not just a single point. This is really about what you treat. After you know that cerebral vascular intervention, basically using guide wire, catheter, and navigate blood vessel. Normally for the femur, go up all the way to the brain, and sometimes using hand. But femur is better, easier to go up the brain. And then, depending what you do, most of it using diagnostic, but therapeutic, you can thrombectomy for stroke, aneurysm, embolization, angioplasty is the same thing. But you need a wire able to get there first before you put a stent or create up. This is a standard procedure. The issue, what's the issue is, for stroke, blood clot by stroke, you need to do it within 6 to 24 hours. Otherwise, you're in trouble. And standard care using the TPA, EVO, 30% of cases. But the problem is only about 15% of people, 10 to 15% people, really benefit for this procedure. Why? Because there's not enough specialists able to do this procedure. As I mentioned before, we are not enough specialists waiting for things to happen. It's costly. So AI, the purpose of AI is really is, can you amplify the knowledge of the specialist? And this is the adding value for high volume center. People, a center do a lot of high volume stroke like methodism, not marketing. We are very high volume, so we have a lot of good surgeons. Our accuracy is very good. If you go to a rural area, have no experience, very dangerous game. So you want to really disseminate the knowledge for high volume center to no volume of rural area. Give you some idea. This is a very standard cath lab old stuff, right? 70 years, do it every day, workhorse. Basically, you stick the wire, you do dia, you see how the wire go in, you see it, you see the catheter, you see the artery. Basically, what artery is the catheter in? That's all it is. It's a very simple procedure. But imagine it's very delicate. You don't want to pop and burst the vessel. It's very deadly. And the whole idea nowadays, a lot of people start playing robotics, right? This is robotic, and instead of a whole Da Vinci machine, the next generation is really a catheter-like, a small, agile catheter. This one, the surgeon will manipulate, look at the video, and patient here and do operation directly. This is how we do it. The problem, this machine is still relying on human. So basically tying the human. As I say, there's not that many specialists around for you to tie in, and you can automate it. So these are the issues. We're adding the AI really replace the eyes of a physician. And this is how the future will do. And give you some example we have done. Now, what is the challenge? I think this figure hopefully can tell you the challenge for people interested in pattern recognition. There's a lot of wires in our body. It's very hard for a computer to tell. And you do very accurate. You're about 1 to 2 pixel thick. Catheter pixels are less than 1% of total pixel size. And 1 to 3 pixels thick in the distant tip of the catheter. And all these challenges are, we actually, without much time, we do develop a deep learning algorithm to solve this problem. And we're using this thing with the thing. We can do the catheter directly, just like Google guiding. You can guide the wire directly to locations. And even you can show the vessel. This is for human only. For computer, you really don't need it to do it. And this is a challenge. The way we are doing it right now, the accuracy is very good. The dice ratio is 0.95 overlap. Excellent result. And the human cannot even do that good, actually. And these are the automatic wiring guided by the AI algorithm. This is some example I show you. This is the ground truth. And this is AI guided. And this is basically dice variation per patients. And this error rate, very low. These are the things are not a blue sky thing. These are real stuff going on right now in the robotic surgery world. And more people will do that. And the whole idea, if you can do that, and in a rural area, what you need is just to stick the wire, you guide it in, reach a location. The hardest part is reach a location. Once you reach there, the local surgeon knows how to do it. So in this case, you don't have to rely on the expert every time you go to the emergency center. But at the same time, really, if this is working, you're really changing the concept how stroke care will be done, right? The model is used to be everybody should rush you here, right? Now you don't really need to. It's directly, remotely, you can rural area, outpatient center, physician office, ambulance. When most of the time stroke patient get in trouble is they send to the wrong center without any expertise for stroke. And by the time they say we're missing it, they take another hour to get another place, too late. Time is spring. So all these concepts, you really create a concept of hospital without wall. And this is how AI can changing the next generation of medical care. So I think I quickly to show one case study on stroke, and you can apply to many care. But the point is, medical AI integrate a lot of real-world data. Besides our traditional alphanumeric data, now you are talking about video, voice, anything you are talking about, this real-world data, real patient data. We have ability to capture it. And this will be involved in the medical AI. And it's not just, I show you an example, you reduce cost, fraud, and all kind of things. You really actually reduce the staffing issue and let maximize the physicians. Physicians should have more time to facing a patient, is automate the physician mundane task. And again, in medicine, the most important is validation. And I didn't emphasize more and more, but there's different type of validations. There's a model shift in AI, and people work in AI know that. So there's a new protocol. The IT will start look at quality control, standard operating procedure, to evaluate the model. Procedure change, imaging protocol change, drug change, and different procedure. All these model will change. So you do make sure your original model still work, otherwise you modify it. So one thing I did not mention it is, this thing is a very tough issue, the empathy. Medicine is about humanity, frankly. And the physician and patient relation is very important. It's not cold science. It's not precision science, that robot. You're dealing with a human being. A virtual doctor compared to real patients is huge difference. So empathy part is improving a lot these days, especially a large language model. You can see more. A lot of Hollywood, the graphic people start putting lifelike image, but they're still missing the AI part at the back. They already have all the computer vision. They can track everything. They can segment everything. They are missing the feedback loop. And there's a lot of progress in this area. I think it will be interesting. So if all this can be true, you ask if some kind of the philosophical questions, right? If this automation, what will be the role for future physicians? It will change. And what will be happen to the patient-physician relationship and experiences? Because there's a completely different, we ask different questions again. These not far what we are stretching. Our head is closer than what we think. The technology has improved a lot, and there's a motivation because of cost factors. And I think a lot of people try to get into this space for interesting anywhere. Anyway, thank you very much. This is my AI medicine group, and also work some of our students from MD PhDs from Texas A&M, and some of my collaborator previous students at Penn State, and support. Thank you very much.